Okay, hello and welcome to the CHA Special Interest Group, our regular monthly discussion evenings. We're talking about pharmacy and medicines management today. My name's Helen Tucker. I'm president of the Community Hospitals Association. This session was to be chaired by Evelyn Podger, who's the chair of the Innovation and Best Practice Programme, but unfortunately she's unwell, so I'm stepping in. But congratulations to our four presenters today for getting their National CHA Innovation and Best Practice Award. Fantastic. And I know the panel were so impressed with what you were doing, and they certainly wanted us to share it far and wide. So hopefully this evening will be a chance for us to listen to what you've achieved and very importantly, an opportunity for members to ask questions.
Right, can you see my screen?
Yes, thank you.
Yeah. Right. So this presentation is about a new pharmacy intervention recording tool that we have implemented in the community hospitals in Powys. In pharmacy, we ensure that we ensure effective and safe management and use of medicines, and we always put the patient first. So pharmacy interventions is basically everything that we do on the wards daily to be able to achieve those goals. Now, recording what we do every day, recording the pharmacy interventions, is very important because the data that we collect will inform on services planning, for example, identifying training needs, any gaps, any specific needs for guidelines or new SOPs, but also informing on key trends in prescribing by identifying and prevent errors, medication errors, informing prescribers on their practice, and identifying cost savings opportunities. The issue is that when we don't record those interventions, this may happen. So this is a domino effect that will end up having the patient with poor health outcomes, and we don't want this. However, in Powys, in the community hospitals, we were recording, we were actually not doing that much recording. So the first thing we've done was to understand where the problem was. In Powys, we recorded an average of 0.4 interventions per staff per week. And if you look at the numbers, that's half a task per staff per week, and we do obviously way more than that every single day. So why weren't we recording more interventions? So this was due to three reasons. The first one was about motivation and management. The second one about staff and time. And the third one was about recording systems. So from that point on, we established targets for our quality improvement project and started our improvement cycles. So how have we done it? We thought that improving the existing recording system was very, very important. So in Wales, we've got AWED, that is the All Wales Intervention Database that you can see on your left. And this is a nationally accepted tool to record interventions. However, our stakeholders in the beginning of the project, they said that this tool was slow, was clunky, and it wasn't fit for purpose specifically for our community hospitals in Powys. In Powys, we don't have a DGH, so you're quite unique in our setting. So we have to have a tool that takes that into account. So we have decided to come up with our own tool, xPIRT, the Pharmacy Intervention Recording Tool. So xPIRT can be used on our tablets, on our computers, on our phones, and uses a Microsoft Forms. Very simple, very quick, and everyone has access to it, and it's free. Automatically, in the background, this data from the Microsoft Forms is collected, is transformed, and is presented in a real-time dashboard. So our dashboard looks like this. The dashboard uses 3 different Microsoft apps. They're all free and they work in the background. So the user doesn't really know what's going on, so they don't waste time looking for data, numbers, and organizing and making graphs. Everything is done automatically and in real time. The interesting thing here is that the user can see the data in real time. So this is very, very important because it improves motivation to record more and more interventions. So everyone can filter data by hospital, by staff, by date, by medicine, yellow cards, incident reports, intervention type, intervention severity, etc., etc. Everything is very interactive. And this is available in our team's channel, so it's readily available for everyone within our team. So what happened after this? We saw a 600% increase in the number of interventions that were recorded. This was during our QI project. However, that median is still the same, so this showed how effective that change was. Secondly, all staff is recording interventions, so everyone is involved in the project. But there is more. Staff they are happy, the team is happy to use the tool. So the satisfaction went from 2.5 stars out of 5 in the beginning of the project to 4.9 stars out of 5, so almost 5 stars. The staff also said that interventions now are less of a challenging competing priority. And we assume, with this sentence, we assume that it takes less time to record interventions, and that's fully because of a new tool is used. We have also, with the data from the dashboard, we have been able to identify key issues around prescribing and suggest new guidelines and formulary changes to be made. Every year, we produce a hospital ward specific poster with a summary of all the interventions done in that year, and this is presented to everyone on the ward, so pharmacy team, prescribers, nursing staff, everyone. We are also involved in meetings with prescribers, so regular meetings. They're usually clinical governance meetings or harm and mortality meetings, to be able for the pharmacy team to provide this data to the prescribers, and the feedback has been great so far. Finally, this tool has been extended now to care homes, and we are very interested to see the results of this. It's very important. And where are we now? We have presented this project not just in Wales but across the UK, to professionals across the UK, and this has generated very interesting discussions around pharmacy interventions and around the place for this tool, not just now but in the future. As part of that, we have been talking to our EPMA implementation team to understand how our tool will fit in on our wards with EPMA in place. We are now in a pre-implementation step of EPMA, so we still haven't decided our system, the system that we will use, but it'd be very interesting to know where's the place for this tool, so we don't clash with EPMA, so people don't duplicate any information. But time now will tell how that coordination will look like in the future, but we are all sat at the same table, and that's great. So everything is very positive so far. And that's it. Thank you very much. Thank you very much.
Let's hand over to the next to the team then, to Rebecca, Laura, and Dan from Sussex. Over to you. Please share your presentation. That'd be lovely.
Okay. Is it sharing?
Perfect.
Yeah. Perfect. Okay. I'll do Rebecca. Yeah. Okay. So yeah, we'll be talking about our EPMA system. I think all of you might be aware what EPMA is, but just in case not, it's the Electronic Prescribing and Medicine Administration. So what we're talking about here is electronic drug charts. So in terms of our journey at SCFT for implementation of EPMA, started back in 2019, if anyone can remember that far back, pre-COVID times. It was actually hot off the heels of the introduction of our own in-house dispensary, which of course is going to be a very important part of this story as well. Our chief pharmacist wasn't just, content with having a brand new dispensary. She was really keen to take advantage of the last kind of opportunity to get matched funding, which is obviously vital for projects like this to get EPM off the ground. So from the outset, it was very important to us that this was going to be a big collaboration between medicines management and digital. I think both sides recognised very early on that this project could not be achieved by either of those without the other. The project team consisted of clinical experts, digital and non-digital, IT specialists, configuration analysts, business change analysts, the training team, the project support officers, who were very important because they were the people providing on-site support from about 7:45 in the morning until 11 o'clock at night for almost a year across all of our wards. Our first ward went live in May 22 and the last in March 23. And I think the length of time it took to roll it out really just showed what a complex effort it was. Obviously, being a community trust covering the whole of Sussex, we have at that time we had 14 wards spread out a long way. I think it's Crowborough in the east, all the way to Bognor in the west, and all the way up to Crawley. So why do people want to implement EPMA at all? So I've got some of the reasons up here, and I'll be like, prescribers handwriting anyone? Of course, not all, but some can be very, very challenging. Missing drug charts, the prescribing of allergens, missed doses, so many reasons, well documented. The EPMA has efficiency benefits and it has patient safety benefits. We want to save time locating charts, and I'm sure everyone knows charts really do have a habit of going missing. Charts could only be accessed by one person at a time, and we spent a lot of time traveling between wards, especially the non-ward based people like the pharmacists, infection control, lots of traveling. And it's just a very, very paper heavy process to order medications. I think it's important to say now, well, why does this make us special? I mean, lots of people are rolling out EPMA. It's a very, very common thing. Well, we decided that we weren't just happy with having an EPMA system. We wanted an EPMA system that talked to our dispensary so that we could get rid of all the processes that it takes, to order medications. We actually had two different systems running. So the EPMA sits within our existing electronic patient record, and we have a completely different system running in the dispensary. And we wanted these systems to integrate, and that was very, very important. And what I'm going to do, I'm going to hand over to Dan, who's going to tell you the story about the integration between our two systems.
Thanks, Rebecca. Yeah, I mean, the story could take days to explain, but I'll try and run through it in a slightly shorter time than that. So I guess the most important thing is that this was a first of kind integration for both these suppliers. So while our pharmacy stock control system, which was Careflow Medicines Management, had already done some interoperability work with some other EPMA providers, this work was the first of kind with TPP System 1. So we trialed this system and we set it up. One of the best things about that is that it meant we could tailor it to our own needs. So it was completely designed around what we needed. But it meant that everything we've done had patients in mind, and it was all patient focused, so that for the next trust that decided they wanted to do this work, it was all done for them. Perhaps one of the hardest challenges was supplier engagement. Both of the suppliers are fire compliant, which is, as some of you probably, hopefully, maybe all of you know, is the framework for these digital solutions to be able to talk to each other. The difficulty about that is that they also interpret that standard differently. So although there is a standard to work to, it's actually very open. So it meant initially they didn't talk to each other. So it was working with them to basically design the talking as well as the systems on their own. And I think it had a lot of benefits for us. It's allowed us to order medicines automatically. It saves so much time. There's reduced errors. And it means we can get patients medications to them a lot quicker and a lot more safely than ever before. So I'll hand over to Laura, I think.
Right. My turn. So my name's Laura. I joined the EPMA team as a project nurse. So my role within that is working with Rebecca and Dan and the digital team to be that link between what's happening with digital and the nurses on the ward, and to be there to make sure we've got communication so the nurses were on board, so it didn't feel like a digital innovation that was being done to them. So a real key part of my role, as well as working with Dan and Rebecca, was to make sure that we kept that communication going. So this is just some of the tweets, as it was, that we put out. So being a community trust, we had to do one ward and then another, depending on location, when we had, maybe 2 or 3 wards in the same location. So we just sort of did this rolling communication of like, we're coming to you, we'd go and see them a week or so before, we'd make sure they had information, provide them with posters, answer questions, show them the demo. Because again, being community trust, you've got that challenge of the time from the first ward going live to the last ward going live, and especially those that may be at the end of the list thinking, well, it's never coming to us, it's taking forever. So it was really, my role really felt about trying to make sure that they felt that they were included and they were coming, and then when their turn would come, that they were ready. So that's just some of the tweets. So just a few little numbers. So in the last year, it's a little bit out of date now. So when the project ended, the EPMA project team, we trained 49 prescribers. It's probably more than that now. 31 members from the meds management team, 7 managers and service leads, 11 matrons and sisters, and 228 nurses. So 326 members of staff. Again, being community trust, we've got to do that on that rolling programme. So those numbers, we haven't updated this slide for a while, it's probably a lot higher. And then as a team, during that rollout period, we provided 26 weeks worth of on-site support. As Rebecca said, our floor walkers were there from 8 o'clock in the morning till 11 o'clock at night, including weekends. We produced 40 quick reference guides, 24 practice notes guides, which was where something needed that digital how-to, but it needed that clinical rationale and why. Rebecca was key in producing those documents. Again, back to communications, the EPMA newsletters and that challenge of keeping the wards that have gone live up to date with the changes that were still happening, and keeping those wards still to come engaged and interested. So it became a bit of a challenge when that balance shifted from more wards on than not. And part of that, as I said, was communication with the nurses. So every time we left a ward, we sent out a survey which asked some basic questions like how they're feeling, what's surprised and what's worked, what's not. And then we used those communications to tell the next wards what the previous wards felt. So it wasn't us as a digital team going, we've got this digital thing and it's really good, you're gonna love it. It was the words of those that have used it. So these are some of the feedback that we got, with some pictures. I've forgotten about that slide. So happy nurses with masks on, you can see them smiling. So some of the feedback we passed on: be confident, have faith, it'll be easier, it's safer for patients. Nurses really quickly recognise the safety and efficiency. You'll find it easy to learn, it's safer. We'd like them to know that EPMA is worth it, it saves time, stress, prevents errors, it's worth it, relax, it's not too bad. Don't worry, you're already familiar with it. I love the feel the fear and do it anyway. That was a good one. Safe system, less medication errors. So as you can see, they were really quickly noticed the benefits and embraced those. I think, did we have another one? Oh, the next one. Oh, no, go back one. Ordering is so quick, we can top up a patient's medication in less than 5 minutes. So again, prior to EPMA, nurses were having to scan charts, send emails. The whole process very laborious and took ages. They can now just go on, see the medication, click and do that ordering. So that's been one of the key benefits they've absolutely loved. They've also loved the fact that you could see the medication and what's due. So rather than having to go around the whole ward at a certain point in time, you can just see it by the time. 12 o'clock, I've got 2 medicines due. So it's a real time-saving benefit, and our number of our missed doses and late medications has reduced as well. Rebecca, I think I've gone onto your slide, sorry. This was the doctor's feedback.
I should be unmuted now. No, that's absolutely fine. So since we last did this presentation, I have begun to look at some of our post-go live benefits realization data. And actually, I've worked out that it saves 17 hours a day of nurse time trawling through paper medication charts, and I couldn't believe that. 17 hours a day. So we have 13 units, so it's across all those, but that, that's the kind of numbers that are beginning to come out now. If you could just move on to the next slide now, I think you've pretty much covered those. So obviously patient safety benefits, it's one of the huge drivers of the implementation of EPMA, and when I say that, I mean our integration as well, because we're really proud that actually we did both of those at the same time. Laura's just explained the due medication functionality. So not only does it save them that huge amount of time a day, it also means that they're really confident that they haven't missed anything, because if they've missed something, it will still be on the due medication screen, and they will know they've missed it, and just sort that out. We have a placeholder functionality. So this is where we can record medications onto a chart. They're not for administration, but it just builds up a picture of a patient's full medication. So something perhaps that they have administered elsewhere, or just get administered every 6 months or anything like that. All of our charts are always legible all the time. They're always clear. And this ability to access remotely has been huge. I mean, we always said it would have been a game changer if this could have happened during COVID, but at least we have it now. Medications are clinically screened by pharmacists quicker than ever before, because we can work remotely. We can see the TTO prescriptions a lot quicker. So we're screening more of those than ever. And also it's going to allow opportunities for discussion about perhaps our own out of hours prescribing provision, because we could now have a prescriber based in Bognor covering, the whole units for out of hours. So it really opens up all of those discussions. I don't think we have a slide about this, but I thought it was really important to talk about the inclusivity, diversity, and also sustainability. So we've touched on it before about how we wanted people to feel like this was happening with them and not to them. And we access such a huge amount of talent in our nurses and prescribers that work on our wards. I think it's really opened their eyes to opportunities that might be available to them. Obviously, if you look at some of the countries we're recruiting our international nurses from, a lot of those have a very strong IT and such background, and it's really opened up their eyes to opportunities for them. In terms of our sustainability agenda, I think we, who with Care Without Carbon, I think loved speaking to me when I met them at one of our conferences, because they could see just how this meets what they want us to do, which is not just jumping in cars. And the infection control team are always telling me how easy it is now, because if they just wanted to look at a chart, they didn't need to meet a patient, but they needed to see a chart for something to do with infections going on that unit, and they had to drive in their cars. And we could be talking, a two-hour round trip from Brighton out to one of our units. So these benefits are really huge. Next slide, please, Laura. Quite sure where we're up to. So yeah, what happens now? So as part of the project, as it came to an end, it became obvious that we'd need to do something. It's not a project you can just introduce and then walk away from. Some projects are, but this certainly wasn't. So the chief pharmacist actually created my role new back when we started to roll out. So it's a brand new digital pharmacy role. And I work to maintain and embed, evolve and optimize the EPMA system, because as we all know, processes do have a habit of changing. And on each ward I go to, they've changed in a completely different way. So it's a lot to keep track of. The most important thing about EPMA is if you don't use it properly, you can't make the most of the safety benefits. So there's lots of things, will only trigger if you use the functions correctly. And it takes time to use some of those functions. There are some more complicated prescribing functions that once you've learned it, it's really worthwhile learning it, because the safety benefits are huge, and people just need more support with that. And they have that. And they've said they like that, because before they'd have to submit a ticket, they now can phone me, they can email me and contact me directly if they need the support. I'm beginning to work on the benefits realization paper so that we can start to prove that it was worth spending all that money on. But going forward, I think you're always going to need someone to maintain EPMA. And I've got Dan in the dispensary who's invaluable at maintaining formulary, and our friends, the DM and D mapping codes, and just keeping everything working as it should. Have I got another slide, Laura? I don't know what's after this one. It might be inviting questions. Oh no, that's it. That's what I'm telling you that I'm doing. Yeah, continue dialogue, just keep speaking to them, building trust. And I think it's time for me to finish. Now, this is how I finished in our presentation for the award. And it's something we really feel is a lot of us made a lot of friends during this rollout. I mean, it was rolling out for a very, very long time. There were times, and it was in the middle of the winter, and it was snowing and it was cold, and we were on the ward at 5 o'clock in the morning because we had to do quality control checks before going live at 8 o'clock in the morning. And you learn a lot about someone at that time in the morning. And I think Dan has fond memories of a big takeaway suddenly arriving on a ward very late at night, you know, because they were bored. What should we do? Let's order a KFC. And I said, you know, you learn a lot about someone when you're sat on a ward at 11 o'clock at night with nothing to do, because the nurses feel confident just to go and have a go by themselves. So it really was. It was 90% the best job ever. The other 10% were, well, we've forgotten about it now, hardest job ever. But it was, honestly, it was a delight. So I just wanted to share everyone that, you know, it really was a really wonderful thing to do. And thank you.